usable. And so we're not going to do a deep dive PhD level dissertation on anything, but I want you to hopefully give you tools that you could take back to your practice and help your patients. I used to do lectures, and my medical school actually had integrative medicine programs, and it was neat because they used to fly me in to teach, 7 or 8 times over the course of a few years, which is pretty cool because I went to school in the Caribbean. So it was a nice little vacation for me. And then the lady who ran the program, we sat down one day. She was my immunology professor. She goes, "John, yeah, your lectures, you have interesting information in there, but I learned so much more just talking to you and sitting down and talking to you." So ever since then, I made my lectures more like a dialogue instead of like a lecture. So I'd really like to, to do that today. So if you have something you want to discuss, you have a question, you have a something you want to add to the conversation, please, by all means. I noticed there's a lot of PharmDs and pharmacists on the list. What's up with that? You just want to expand your knowledge? Are you guys like seeing patients outside of being a pharmacist, or I don't know if there's any pharmacists here or PharmDs here.
I need the CD credit.
Oh, okay. Got it. Okay. Very good. So anybody know what integrative medicine is? Because it kind of has a lot of different meanings, right? And we're going to go through nomenclature, but hopefully I've been around this stuff for a while, so I kind of hopefully have some kind of framework that will be informative for you guys. And there's no clear division of topics, so some things will fall into a number of different places. So it's a matter of just getting everything up to speed. You got stuck already?
No, it should.
Is this a pointer too? Yeah.
It should work for you now. Yeah. Sure, which get this is. Here you go.
Okay.
Okay.
Forward is this way?
Yeah, up and down. That's the laser.
This is the laser.
There you go.
Oh,
Okay, down.
down is forward. Got it.
And it will point straight.
Okay.
Maybe I can work roughly.
So financial disclosures, I have no financial conflicts of interest. Unfortunately, nobody pays me any money to do anything but what I do. Okay, so my rules of integrative medicine. First, keep an open mind, because there's a lot of different treating paradigms out there, and what we want to do is pull the best ones in for our own personal use. Next is first, do no harm. All right, that's the classic medical proviso. Always examine the risk-benefit ratio of treatment, or the risk, and sometimes it's the cost-benefit ratio of treatment too, but depending on your patient base. But always start with the most conservative care first. That might seem kind of basic and silly, but you'd be surprised how many people don't start with the most, depending on where they are in the medical paradigm. Remember cause versus symptoms, right? Don't suppress the symptoms if you can treat the cause. And that's what functional medicine and integrated medicine is about, is doing root cause analysis and finding the cause of the problem. So I used to teach to the medical students, and I was on faculty at Kaiser Chiropractic Medical College for a while, teaching integrative, or actually teaching laboratory science. So the question is, if you're sitting on a TAC and one Tylenol takes away half the pain, what is the proper dosage? Get off the TAC, right? You'd be surprised how many medical students miss that. But it's just basic common sense. And sometimes there's no common sense in medicine. So hopefully we can change all that. So how did I get into this? Well, when I'm talking, people, ask me, well, how did you get into integrative? When did you start integrative medicine? And if I'm talking to lay people, I say, well, about 1991, when I took my first functional medicine seminar with Jeffrey Bland. I'll talk about him in a minute. But I talk to doctors, I say, well, I was in chiropractic practice for 10 years with a nutrition background. By the time I got to medical school, so the toothpaste was already out of the tube by the time I started doing this. So, and as I said, my medical school actually had integrated medicine programs, and we usually have courses in nutrition. So sometimes I get all different kinds of patients, and some people say, well, you're an MD, you don't have any, MDs don't know anything about nutrition. I get a lot of feisty patients. And I say, well, that's pretty much true, but my medical school actually had 2 courses in nutrition. And they're like, oh, I said, and then I have a bachelor's in nutrition and a master's. And then, we're on the same side. I have a very, people seek me out because I have a kind of unique practice, and they're looking for not only traditional care, although some are, also different ways to do things, more conservative care. So along the way, I, went to Life, did some sports certification, nutrition certification. I was an instructor for activator methods, which is a chiropractic technique, and we'll talk about that a little bit when we talk about manual medicine. Then I just decided I wanted to go to medical school, so I said, well, let me do a master's so I could warm up to medical school. So I did that. Then I did my, graduated from St. George's, did my residency in New Jersey in internal medicine. And then as soon as I was done, I moved to Florida because spending 2 years in the Caribbean, you can't stand the cold anymore. And I've been doing this for a while, and I couldn't practice any other way, I don't think. So if you're anybody really new to functional or integrative medicine? Okay, so this is going to be very overwhelming at first because you're just getting information from all different kinds of ways, and hopefully Lynn and I could provide a framework for you to kind of sort all this stuff out. And then when you first get a little bit, your feet wet a little bit, you're like, oh, this is pretty easy. And then if you've been through this a while, you're like, well, the more I know, the less I understand. Because it just gets, as you drill down, it gets more complicated, and you're like, "Oh, this is impossible. I can't figure this out." And then if you've been in it for a while, you start reading and you start studying, and you just get some experience in it, and you say, "Oh, okay, this is kind of pretty cool." And then you say, "Well, okay, I got a handle on this." So, and we're all on the continuum somewhere. And every time I think I have a handle on something new comes out in the literature, or something else is discovered. So this is a good thing to be constantly learning. Sorry, the wrong way. Oh, this is the Dunning-Kruger effect. And then this is not a nice way to put it, but when you think you know everything, that's when you're in trouble. And that's usually at the beginning. Okay, but then as you go through this, you kind of get the hang of everything. This is my view of the world. This is how I look at my practice medicine. And it took me a while to come up with this. And if you have any improvements to it, please let me know. But this is how I look at things. So starting in the middle is the genome, right? The genes. The signals to the genes, the epigenetics, right? And that is kind of what our base is like, right? But just because you have the genetic propensity for something doesn't mean you'll ever manifest that, okay? The saying in functional medicine is genetics loads the gun, but lifestyle pulls the trigger, okay? So just because you don't have the genetic propensity for something doesn't mean you can never get that particular disease. The genetics and the genome study is very complicated. We're starting to be able to test it now. But if you've been doing this kind of stuff for a while, and we'll talk about testing later, sometimes the testing hasn't caught up. It's not there yet. It's not ready for prime time. Okay. So genetics gives us a little bit of things. I do test certain things. I do test APO4, I do test AOMT, I do test MTHFR. Those are the big ones. Now the other ones, because it could be hundreds of genes interacting with each other. So that's kind of tough to nail down. So just take the genetic stuff for what it's worth, but know that lifestyle really makes the big difference. Oh, and please, if you have questions or anything, please stop me along the way. So our next ring is lifestyle medicine. and I'll give you the background of lifestyle medicine in a little bit, but this is basically just what lifestyle do you lead? What's your diet and nutrition like now? But when I say diet, I mean, what are your macros? What are you taking in? Not a short-term plan designed to gain weight, lose weight, or whatever. That's a diet, but that's not your dietary intake. So what are your macros like? I'll give you my biases. I am proteocentric, I'm protein centric, and I'm myocentric. I'm about keeping as much muscle on you as possible, lean muscle. Okay. Because your strength is tied to your longevity, right? Your lower extremity strength is tied to your all-cause mortality, actually. Okay, so I'm about keeping as much muscle mass on my patients as possible. It says H2O, but that's water, but that's not really water. It's really hydration. Right? How well hydrated are you? Hydration is not just about water, it's about the minerals that go in the water. We're more like ocean water than we are lake water, right? With all the dissolved minerals in there. Stress management. Do we teach our patients about stress management? You're smiling at me. You teach stress management? Yeah. Okay. Is it very important? Absolutely. Yeah. So do you have your patients meditate? Right? Can you teach your patients how to meditate? I used to teach, when I used to go down to the Caribbean, I used to teach stress management for the med students. This is the days before iPhones, and now they have all apps. I mean, there's different apps you can have on the patient's phone. Calm, Headspace, there's a bunch of them. It will get them into, just it makes it easy for them to meditate, to go into, a mindful state. Breath work. Okay, can you teach your patients how to breathe? Do your patients know how to breathe? Are your patients stressed? Are they too stressed to breathe? Well, instead of taking deep breaths, they're all tight up in here. Socialization. We're finding now that people who are socially isolated, we found this with COVID, much higher incidence of morbidity and mortality. Okay, do your patients have a cause? Do they belong to something? Do they have a social support group? Do they have friends? Okay, very important. Lifestyle stuff is really where, that's what I call preventive medicine. And that's how I explain it. This is all preventive medicine. Right? You can do this. This pretty much is, a lot of this is free. Right? Your patients say, well, I can't afford this, I can't afford that. Well, patients can afford what they want to afford mostly anyway. But that's free stuff, right? Exercise and activity. Are they the same or are they different? Is exercise and activity, are they the same things, or is exercise different than activity? They're different, right? Activity is just moving, not sitting, right? We found that sitting is the new smoking, right? If you sit more than 4 hours a day, or if you sit down and you're not doing anything intellectually challenging, right? You're just sitting there passively watching TV. Well, that's not good for your brain. But if you're doing, you're doing work, you're doing puzzles, you're doing something, that's not as bad. But you still got to get up and move. I have a ring, and some people have watches that say, hey, it's time for you to get up and move, right? They want to keep you active. Well, we're using technology now to help us out. Okay, and this is all good. This is all good stuff. I mean, my ring wasn't free; it wasn't even close to free. But you don't need that. You can set a timer on your phone. You can say, get up and move every half hour or every 45 minutes or whatever it is. You have to keep active. Exercise has a purpose in mind, and typically it's either muscle building, right, resistance training, or it's cardiorespiratory training. Cardiorespiratory fitness, your VO2 max is tied to your all-cause mortality. The higher your VO2 max, the better you're going to be, and the longer you're going to live. The more muscle mass you have, the stronger you are, the better you're going to live, and the longer you're going to live. Okay. Now, going to the gym might cost you some money, but it's cheap compared to a prescription, depending on your prescription plan. So I try to get my patients to do something. Move. Well, I walk the dog. That's great. That's activity. But tell me about exercise. And I have pretty motivated patients. So I want you to do, I want you to do resistance training. Right? Well, I don't like to go to the gym. Can you find stairs? Yeah. Okay. Walk up the stairs and you're going. The stairs are the best natural. I call it a natural stairmaster. You walk up and down the stairs. You have to motivate the patients to do it, and sometimes that's the trick. Depending on what your practice is like. If you're in a managed care organization, much less than people who are coming to see me paying out of pocket. But you can still do what, you can still make a dent in these people's health and lives. Exposure management. Do your patients smoke? Right? I don't know. I mean, I know the percentage is going down, but I think somewhere in 20% or a little less of the people in America still smoke. Okay. Are they exposed to pollutants? Where do they live? Right? Are they in the city? Do they filter their air? How is their water supply? Right? Do they filter their water? Right? Okay. These are all important things that, we want to limit what our exposure is. Do they work the midnight shift? Right? Do they work in 12 to 8 and throwing off their circadian rhythm, their chronobiology? Okay, so that's certain, that you might not be able to get around, but if the patient has the choice between not working the midnight shift, I work with a lot of firefighters, police officers, and a lot of them, the firefighters typically have that 24-hour shift. And the police officers, sometimes they get the overnight shift. So we have to work with them to try to restore their circadian rhythm. How do you do that? Well, you get them outside. I live in Florida, so we send them to the beach to ground. Okay. There's certain things that we can do. Sleep management. Sleep is probably the most important thing, probably the toughest thing to do. And we have a little bit more on that as we get later into the program. But if a patient can't sleep, they can't be healthy, period. Sleep is when you restore. Sleep is when you drain the junk out of your brain, right? The lymphatics system that operates when you're sleeping. If you can't sleep, you're not doing that. Okay. You'd be surprised how many patients have sleep apnea. If your neck is over 16 and a half, you have a 95% chance of having sleep apnea. Just as an anatomical thing. Okay. Patients who have sleep apnea are hypoxic by definition. Okay. If you can't sleep well, you can't be well. So that's, if I had to pick one thing that I would concentrate on the most, it would be sleep. Okay. Now, do the other stuff help with sleep? Yeah. Right. If you exercise well, you might drop some weight and you're probably tired and you probably will sleep better. I know I sleep better after a day that I work out than days that I don't. Okay. What is your sleeping environment like? How many people stayed in the hotel last night? Okay. Do you guys have a microwave in your room with a green light on it? How many people unplugged it? Right? Good job. Blue light, green light at night disrupts your sleep. Okay. What you're sleeping, you should have a sleeping sanctuary. What should that look like? Total darkness. Total darkness. Okay. Because we have not only light receptors in our eyes, we have them on our skin too. So blackout curtains in your room. Traveling, it's tough. This is actually a pretty good room because usually when I go to places, there's blinking stuff, and lights and smoke alarms and things that have all kinds of lights. So sometimes I go around, tape them. But I sleep with an eye shade, right? To get the total darkness into my eyes. Is it important? Yeah, it is. Yeah. You guys do that too? Yeah. Okay. These are just little things that it's so important to just impress this upon your patients because this is easy stuff. This is stuff that takes little to no money, and everybody can do this, and everybody should do this because it's much. I always, when I speak to firefighters, what's the best way to put out a fire? Like prevent it. Yeah, right. Exactly. Preventive medicine. Oh, there's a typo in here. So hormetic interventions, not hermetic. That must have been the old slide. Anyway, so hormesis is something a little bit is good for you, and a lot of it is not good for you. Okay. So fasting, right? Intermittent fasting, time restricted eating. Anybody hear of this? 16:8 or whatever, 12:12 or whatever it is. That's good for you. Exercise is good for you. Heat stress, saunas, okay, release heat shock proteins. Cold plunges also release heat shock proteins, and they should be cold stress proteins. They help keep you healthy. They keep your proteins folded in the proper three-dimensional things, three-dimensional shapes, right? But this is easy stuff. Chronobiology. Don't be up when don't be up midnight to 6 a.m. That's when we're designed to sleep. Okay. So you synchronize your circadian rhythm. How do you do that? See the sun rise, see the sunset. Okay. Easy stuff. This is easy stuff. Okay? But it's important. Okay. We need to live in sync with nature. Okay. Any questions on this stuff? Anything to add? Anything you don't understand? Okay. So that's lifestyle medicine. Now we go to functional medicine. Oops. Okay. So functional medicine, these are the things that we do to try to get to the root cause. Okay. So it's not just basic blood testing. It's not just, the typical heart and lung exam that you might get from an integrated or internal medicine physician, family physician, right? We want to look for different causes. We want to dig deep. I start everybody off because if patients over 30, 35, I typically test their hormones because typically I see a disrupted hormone. Men are losing about 1% of their testosterone every year. Okay. Typically they're losing 1% of their strength every year. So we want to make sure that their hormones are optimized because that's the easiest thing to do with bioidentical hormones is to make sure that that level is up. So advanced physical exam, you guys see patients. Do you guys test grip strength? Good, excellent. Do you guys test one-legged standing?
Physical therapy, so they do most of those things.
Okay, that's good because you want to know functionally how they're doing. Grip strength is tied to lower extremity strength, which is tied to again all-cause mortality. So we want to get that in there. Okay. Heavy metal testing. I test that a lot. My first practice was a chelation practice that I took over. And we did a lot of heavy metal testing because when I was growing up, there was lead in the gas, lead in the paint, lead in the newsprint, lead in the cans that soldered. There's lead all over the place, lead from coal burning fire plants. That dipped down, but now even the coal burning fire plants are coming up. China's still putting up a new coal burning fire plant every 2 weeks. That comes over the jet stream. A third of the pollution in California is from China. A third of the particulate matter comes from China. Okay, so it's still in our atmosphere, goes into the oceans, gets into the fish, mercury also. Okay, so mercury is a big thing. And we see that a lot, and we test that a lot in not only in my practice, but also in the brain center too. Let's talk about manual medicine for a second. Manual medicine is typically done with the hands, right? So I don't think there's no DOs here, and I don't know if there's any DCs that have joined us from the school. But manual medicine is one of the branches of the healing arts. It's been around 5,000 years or more. Okay, so there's three parts of manual medicine. There's massage, or just the force. There is mobilization, which is getting through the full range of motion, and there's manipulation. Now, typically, massage therapists and PTs do massage. PTs typically do the mobilization, although there's some of that in chiropractic and in osteopathic medicine. But manipulative medicine, that's pressure or force applied to either relieve pain or improve function. Okay, so coming from a chiropractic background, I have a musculoskeletal bent, and maybe that's why I'm protein-centric and muscle-centric. But that's a big part of our existence, our nervous system and our musculoskeletal system. So typically that's DOs and MDs, some, and then DCs in this country. But there's a lot of, and also traditional Chinese medicine people do it, naturopaths do it. But a lot of people do it, but it's kind of lost in, it's kind of like a side part of medical care in this country. But it's an important part. So if you use PT a lot, or you send them to DOs or DCs to get the musculoskeletal system improved, that goes a long way, because if they're out of pain or they have more function, they're better off they're going to be. And it's all about the total thing. Organic and biotoxin testing. We're exposed to all kinds of pollutants depending on where you live. If you're in an inner city, you're going to be exposed to a lot of gas, exhaust, cadmium from the tires, that goes back to heavy metals. And so it's just another thing that interferes with the cellular function. So when we're going to talk about cellular medicine in a little bit. It's all about the cellular function, removing the toxins that actually stick to the cell membranes. So there are certain tests, we'll get into testing later, that you can look and say, well, what is my patient exposed to, and how can I get rid of it? So it's pretty much, if your body's polluted, you're not going to function. You're not going to function well. Just like if your fish tank is polluted, the fish aren't going to do well. It's as simple as that. Allergy and sensitivity testing. Certain foods are not good for certain people, and sometimes you don't know that. Sometimes patients can identify, you don't really need to do the testing, but sometimes there be people who you can't figure out exactly what's going on with them. Why do they break out? Why do they have GI problems? We test them and we see what's going on. I do a lot of testing with the microbiome. I do a lot of GI testing. Okay. GI testing tells me a lot about the internal milieu of the body, not only if they're parasites or is there worms or anything else, but is there imbalance between the flora that is there? Okay, do they have leaky gut? Do they have an inflamed intestine? Okay, which is giving them their problem. Do they have increased intestinal permeability, i.e. leaky gut? They're absorbing things they shouldn't, then the immune system takes over, and we're starting to have more problems that way. So that brings us to integrative medicine. Now, in my mind, I just put integrative medicines as the things that you need a license for. Okay, either the order test or the order to write prescriptions. And that's totally, it's totally my construct, but that's just an easy way for me to figure out who does what. So biooxidative therapy, so that's ozone, hyperbaric oxygen, high dose vitamin C, exercise with oxygen therapy. That's not an exclusive list, but that's what it is. Because the more energy you can get through the mitochondria by driving the oxidative process, the more energy the cells are going to produce, the healthier the organism is going to be. BHRT, that's where bioidentical hormone replacement. So that typically you can try to do it. We see people try to boost hormone production with herbs, with other supplements. Sometimes that works. Most times it doesn't, or it doesn't work enough. And then we need to supplement them with hormones. I typically use estrogen, testosterone, progesterone, DHEA, and pregnenolone. Those are typically the ones I use. Also thyroid. I will use natural thyroid. And those are typically what I try to balance out in my patients.
About estrogen and somebody who might have a bad
I want to be aware of it, but we use low doses, and we never give estrogen unopposed. So I will always give progesterone if I'm going to give estrogen. And then for breast cancer, also you typically get testosterone, which is also protective against breast cancer. It's actually related to breast cancer cells. So yeah, I want to be aware of that, and I want to make sure that their estrogen metabolites are healthy, and sometimes they need to be detoxed or have liver some liver detoxification going on to make sure that they're processing everything. Yes. The question was, do I worry about giving estrogen to a person who has a family history of breast cancer?
We have another question. Do you describe range, but below and normal?
Do I prescribe what?
Oh, I'm sorry.
Oh, testosterone.
You describe hormone replacement in men whose lab value is in the normal range, but at the low end is normal.
Okay, so yes, I do. I treat the patient, not the lab value. Okay, and depending on the lab value, it could go anywhere from 300 to 1200. As I started doing this, when I started doing hormone replacement therapy, that was the average. That was the average range. It was 300 to 1200. Well, that's fourfold difference. That's a big difference, right? But lately, the lab values, the upper end of normal, have been tweaking down to like somewhere now they're between 800 and 900. I still use that 1200 as the normal. I was taught this at a seminar. The average age of a 50-year-old man, testosterone level 50-year-old man in 1950 was 1200. That's the average of 50-year-old man in 1950, and the upper limit of normal was 2400. We become an estrogenic society. Yeah, the plastics that we're exposed to, drinking out of, they're estrogen mimickers. The chemicals in the air, the heavy metals, they're estrogen mimickers. So yes. So the answer to the question is yes, I would. I treat the patient, not the, so if the patient comes to me and they're 400 and they're like, I need a nap, but the doctors, and I get this a lot, the doctor said, oh, I'm in the normal range, so I don't need testosterone therapy. I've had guys who had 850, couldn't get off the couch. We brought them up to 1,000 and they're like new people. So yeah, I definitely do treat testosterone levels in the normal range. I try to get them up to the upper level of normal. The statistics show that people who live in the upper quartile of the normal testosterone range, live longer and better, less incidence of cancer of all types than the people who live in the bottom 3 quartiles. So yes, I do. Okay, I do write pharmaceutical prescriptions. I get some people who are very anti-medicine. They come to me because they have heard or they've been told that I can do, I try to work with them so they wouldn't have to take medicine. Goes back to lifestyle changes. But I have people who, they said, I'd rather die. And some of them have, because they didn't want to take their medication. They didn't want to control their blood pressure. I wrote them a prescription. They filled it once to make me happy, and they didn't refill it. And then I have to sign a death certificate. But if you come to my office and your blood pressure is 200 over 100, you're going to leave with a blood pressure medication until we figure out what's causing that. And we have a section later on in the program about hypertension and resistant hypertension. But yes, so that's part of being integrative medicine, is actually controlling the symptom when it's dangerous. Yes, so I will write prescriptions. Regenerative medicine, PRP, platelet plasma. We do a lot of that. Hyperbaric oxygen is somewhat regenerative. Stem cell therapy, tougher to do in the United States. Well, a lot of my patients go outside the country for that. Dominican Republic, Panama, typically. Some people go to the Bahamas, but that's important. And what we do is we get them prepped for the regenerative therapy. What does that mean? We detox them, we clean them out. Stem cells go to the areas of inflammation. So we want to get our patients lower their inflammatory burden as much as we can, because disease is going to be about inflammation, and we're going to talk about more as we go over the weekend. Peptide therapies are newer. Peptides are signaling mechanisms. Okay, they're signaling molecules. They're just exposed to amino acids, but they're upcoming. Very helpful for all kinds of things. Also, regenerative therapy. We use them post-surgically. We use them for hormone or growth hormone improvement. We use them for sleep. We use them for weight loss. We use them for glucose control. So they're really, really becoming a bigger part of my practice. Because they're pretty safe. There's no downside to them. And it's about the risk-benefit ratio. Okay. So typically they come either in sub-Q injections. Sometimes they're oral capsules. Sometimes they're creams. But typically they're sub-Q injections, kind of like insulin. Insulin is a peptide hormone. It's also a signaling molecule. IV nutrition. We do a lot of IV nutrition in both of my practices where I am. We do a lot of Myers cocktails. We do a lot of high-dose vitamin C. We do a lot of phosphatidylcholine or phospholipid exchange to help detoxification, improve cellular function. That also goes under the heading of cellular medicine. Okay, cellular medicine is all about membrane health and mitochondrial health and the mitochondrial membrane. Okay, so we really want to get everybody detoxed. We want to get as much of the body burden of, there's a concept called allostatic load, everything you're exposed to. We want to decrease their allostatic load, get rid of their body burden of pollutants, toxicants, chemicals, so they can have a healthier, more robust cellular function, mitochondrial function, therefore cellular function, therefore organism function. Medical cannabis, Florida is a medical cannabis state. And I use that typically as an adjunct to other things that I do. I don't have a cannabis practice, although there are people in Florida who just do cannabis, but I just use it as an adjunct. CBD, THC, good signaling molecules, they're very helpful. Pain control or autoimmune disease, cancer, those are typically what I use it for. It's not for everybody. You have to be very judicious about who you prescribe that to. For our purposes here, I don't think that really applies to too many. There's only a couple of MDs in the room. And is Pennsylvania a cannabis state? I don't even know. I know New York is, yeah. Any questions on my little view of the world? So under the Obama White House, there was a thing called the Precision Medicine Initiative. And they said, well, we're going to take this emerging approach that for disease treatment prevention takes into account the individual variability, genes, environment, lifestyle for each person. Okay, well, that's integrative medicine. Okay, this has been around for a while. This was I think 2009 or somewhere around that. It came out of the Obama White House. But that tells me even mainstream medicine is trying to starting to figure out that what we're doing needs improvement and not everybody gets the same thing because not everybody is the same person. And we need to look at the individual person, what makes them up genetically, what makes them up lifestyle wise. And we need to tailor our treatment to the individual person because everybody is unique. So older terms, first there was alternative medicine. It's a non-mainstream approach used in place of conventional medicine or orthodox medicine. Then came along complementary medicine, which is used together with conventional medicine. And then it became complementing and alternative medicine, and CAMS was the name that stuck for a while before we had integrative medicine. So this is what the NIH view of the world looks like, and it's pretty good. I like this too. As far as what integrative medicine is, so they break it down into natural products, which I would call plant medicine or nutritional, or plant medicine, and then nutritional portion of it. And then they have mind-body practices, which are very important because there's really no division between the mind and the body. It's all one system. Okay, we just split it up because it's easier to study that way. But that's where we get into trouble too. So then they have the psychological, mindfulness, spiritual practices, meditation, breath work. They go yoga, tai chi. So all the mind-body stuff. This is really good. So then they have the pharmaceuticals, and yeah, there is some overlap here. A lot of the pharmaceuticals were actually derivatives of natural products, natural things in the atmosphere, plants, etc. And then the essential nutrients, food as medicine. So there are medical food products, but what is it? Let food be thy medicine and medicine be thy food, Hippocrates. This has been around for such centuries, right? This is nothing new here. We're just kind of getting this all down. Acupuncture, not a big part of my practice. I trained in it, but I very rarely use it, but it's very helpful. Usually when MDs do it, they do it typically for pain control. I don't see a whole lot of pain in my practice anymore. But a lot of my patients already have a TCM or a traditional Chinese medicine practitioner. A lot of my patients utilize all different sorts of modalities, and sometimes I just play quarterback. They include surgery. They include devices. Devices could be electromagnetic stim. It could be TENS units. It could be, I guess that's just a catch-all kind of thing. The physical, the manual therapies that we talked about, heat, cold, electrostim would also go in there. Anything to improve the musculoskeletal system. I really like this. I really like this, the way they laid it out here, because it kind of encompasses everything and it shows you the overlap, which is something my model doesn't do, but so this is a lot of the patients. How much longer do I have before I have to do something? That's only some of my patients. I have a lot of very motivated patients. So the history of functional medicine, it was founded in 1991 by a guy named Jeffrey Bland, PhD biochemist out of the Northwest. And it's individualized, it's patient-centered, it's science-based, right? People teach you, he can give you more biochemistry than you ever want to know, and he has. You look for the underlying cause of disease. Again, everything's individualized, their genetics, their lifestyle factors, and everybody gets a personalized treatment plan. And that's what's interesting about my job is like everybody's different and everybody's treatment plan is different. It's not and it's not everybody gets the same prescription. and that would be very boring. My job is interesting because I get to do root cause analysis. I get to put on my detective hat and figure out why this person has been sick for 4 years, 6 years, why they've seen 7 doctors before. Nobody can figure out what's wrong. Or this is my favorite. They bring me a basic, CBC and a blood chemistry panel says, my doctor says there's nothing wrong with me. It's all in my head. That drives me nuts. So I say, well, it's not all your head, although some of it might be, but let's figure out what's going on and let's try to figure out what's causing this. What do you need to change? And what are you willing and what are you not willing to do? That's what I always ask my patients. What are you willing and what are you not willing to do? And most of the time, by the time they get to see me, they're willing to do anything. So integrative medicine, Andrew Weil's kind of been recognized as the father of integrative medicine because he's been talking about this since probably the 60s or the 70s. And kind of it's an overlap. They look at the whole person. They want to look at the lifestyle because again, lifestyle is what it drives everything. And then they recognize the therapeutic relationship between the practitioner and the patient. Now I tell my patient, I'm the coach. I call the plays. If you can't run the plays or you don't want to run the play, okay, I'll try another. I'll figure out another play for you to run until we get you where you want to be. But everything is formed by evidence. Well, is evidence just double-blind, placebo-controlled studies? No, right? If you look at some of the you look at Ioannidis' work out of Stanford, you can't even believe most of the stuff that's in the literature anymore. But case studies are evidence. There's a lot of things that are evidence other than double-blind, placebo-controlled studies. When they did control studies in surgery, they found that a lot of the surgery was just placebo effect. They did arthroscopic knee, and sometimes they just put the hole, just put the holes in, and they just did just as well as the people who got the entire surgery. So placebo, we try to utilize placebo effect whenever we can. So you always want to be positive with your patients. Right? You have the expectancy that this is going to work. Sometimes that just makes the difference. Say, well, we'll try this and see if it. Nah, I think this is going to, pick something and say, well, I think this is going to work for you. And I fully expect you to do well. And that's what I say. I fully expect you to do well. And I want to set the positive expectation with the patient because the placebo effect is important. They can give people literally pills that say placebo on them and they will get better. Some of them will get better. So even though they know it's placebo, it still has the effect. So that it goes back to the whole mind-body medicine thing, which I think is kind of interesting. So Andrew Weil, he actually has there's a Center for Integrative Medicine out in University of Arizona. They actually have a fellowship there, which is interesting because very few people do what I do are fellowship trained. But now you can actually go out and get that kind of training. And I looked at the program, and so it's typical to integrative medicine stuff. Okay, so there are the defining principles. We're partners, the patient and the doctor, or the patient and the practitioner are partners in the healing process. And then everything that influences the patient's health and well-being is taken into consideration. Appropriate use of both conventional and alternative medicines will be used. So we want to use the more natural and less invasive procedures or interventions whenever possible. Again, always start with the most conservative care first. That just makes sense. Okay, we don't reject conventional medicine, or we don't accept anything alternative uncritically. What is evidence? What has been shown to work? Okay, doesn't have to be double-blind placebo. Okay. We want to place our care in good science and always be open to new treatment paradigms. My first rule, keep an open mind. We don't know everything, and something new comes out every day. Okay. Sometimes what we thought worked doesn't work. And sometimes that has to be part of your thinking process too. Okay. Well, we used to do this, but now we found, you know what, this probably not as good as we used to think it was. And medicine is rife with that. It is filled with things that on further reflection, well, probably the treatment was worse than the disease, and there's so much side effect. That's why drugs get recalled. Mhm. Stage 4 reporting. So we want to promote health and the prevention of illness. How do we do that? Lifestyle medicine. We want to encourage our patients to be healthy, be well. So practitioners should exemplify its principles and commit themselves to self-exploration and self-development. So I kind of try everything out on myself first, for the most part, before I unleash it onto my patients. But I do try to serve as a good example for my patients, and that's what makes it interesting, because I have to try the different things at first. I try the different diets, I try the different products before I recommend them to my patients, just to see what my personal response was. But it's not lost on the patients when the patients, they tell me, well, I went to see the doctor and he told me I needed to lose weight, but he was 100 pounds heavier than I was. So it's not like that do what I say, not as I do thing. It's just like, here, I can do this, therefore you can. So I tell my patients, well, I'm an Italian kid from Bayonne, New Jersey. If I could give a pizza, you can. And then they're like, well, okay. So once they know that you're going through the same thing, or you've gone through the same thing, or they're more apt or more likely to take your recommendations to heart. So we've talked about this, I think, ad nauseum. Are we back? Okay. All right. Sorry for the interruption. I just need to finish up here with just a couple of things. So this is basically tell you things change before we actually get a diagnosis, right? Things go wrong before we actually start seeing symptoms. And that's part of root cause analysis. You want to be able to also predict or prevent basically what the patient could be possibly in for. So if we can get this early, lifestyle medicine, before we have to do the aggressive stuff, even better. Okay. And these are just the typical things we see that are just like, these are self-inflicted for the most part, self-inflicted diseases. Heart disease, stroke, diabetes. Just about all of these are preventable. Okay, just another graphic, another way to look at it. I like these kind of graphics, like anchors things in my mind. I guess I'm a more visual person than just the data stuff. Questions? If you don't have any questions, I'm going to start asking you questions. So you better start asking me questions. What do you want to get out of this?
It's something that I can use in pharmacy directly.
Okay, I'll let Lynn feel that one since she's the pharmacist. Sir?
More of a lifestyle things I can work with and family on. And you know, I get 20 minutes with somebody, you know, on a good day.
Right. Well, 20 minutes is
Yeah, so that would be the kind of
okay.
thing.
On day 3, we're going to, what's in your handout, probably the medical symptom questionnaire. And that's a good, it's just a good numerical report, review of systems. And then you can hone in on something that patient might not even be telling you. And then you can go back and say, oh, well, Mrs. Johnson, you scored an 18 in this category. That's a lot. You never told me about this before, because they might not have thought about it, or they might not have even thought about it until they actually had to put, you know, a numerical value to it.
Later you'll go over more about sleep.
Yeah, we'll have a thing on sleep. Yeah. But as a family doc, you're on the front lines. You could do a lot.
I'd probably get at least 3 or 4 sleep tests a week.
Yeah, right. Sure. How many patients would you say percentage-wise in your practice are overweight? Okay. How many are under-muscled?
Depending on how you decide that question, probably even more so.
Yeah.
I've been practicing for a while now.
Right. Yeah, if we could prevent frailty, we would go a long way to, you know, because we'll talk about falls and we'll talk about, you know, frailty or because of, you know, lack of muscle strength, lack of balance. And sometimes it's eyesight, or lack of proprioception. Yeah. I told you I was going to ask you questions if I didn't get any. It's fat. All right. Can you put this to use for yourself? Okay. All right, at least then, well, anything you want to get out of this?
I was curious about your success with the PRP. I do utilize that some workers' comp, and it's hard to get approved. They like to deny it. They said there's no good studies, but I know you see them used in Cincinnati on the sports team.
Sure.
15 years ago.
Sure. Yeah, it's you know, it's not a cure-all, but it can be pretty good. I actually go now to, before I do send for PRP, my PA does PRP, but I will use stem cell, I will use peptides first. So I would do peptides, PRP, and then stem cells, you know, in that order. If we didn't get a good, you know, good result, and I would go up the ladder that way.
Got one questions about what do I know about country?
I learned a lot from my patient. So the woman's statement was, you know, she didn't realize how expansive this was and how integrated this was. I get patients who are actually more up to stuff, a lot of stuff that I am, and they bring me stuff that's cutting edge because they have time to sit around and Google and research all day. So yeah, I learn a lot from my patients. So hopefully, you know, you learn from me and then you learn from your patients. And believe me, if somebody has anything they would like to share to educate me, please do.
And any of my communications or family
Yeah.
I do a lot with chemical dependency patients. I wonder how much this would help try to find a root cause of everything.
Tremendously, because everything with the brain to me is all about inflammation. And if we can decrease the inflammation, a lot of these things are inflammatory. So whether we're talking about chemical dependency or any other kind of neurodegenerative disease or dementia, I look at the approach the same way. I want to know what their MTHFR status is. I want to know what toxicants they were exposed to. I want to know what their vitamin status is like. Yeah, so a lot of this is orthomolecular medicine is just, it was basically founded on psychiatric, for psychiatric patients. It's just finding out the right vitamin, that the particular patient needs due to their own particular biochemistry. I didn't skip you. I'm just going to go this way.
Pretty much what everyone else said, just kind of a good overview of this.
Mhm. Yep.
I work with a lot of patients, and I feel like there's so many that have dementia.
Mhm.
Everything. Their CT might show some vascular changes, but then, family like a couple of rib weeks, and then they take a nosedive. I just, one thing in my head, I'm wondering about like metals, toxicity and things like that.
Yep.
But I wouldn't even know what to test.
Well, you will, but hopefully by the end of this weekend. So the comment,
Sleep, too.
yeah, well, sleep is important. If you can, you want to give somebody dementia, don't let them sleep. And the comment was this practitioner works with a lot of elderly patients, and they worry about dementia. So yeah, so you look at are they exercising? Are they even active? Do they sit on the couch all day? So if I know this is like, trying to push a rope, but if you can get them to be a little bit more active, you get them socialized. If you can get them slow changes,
Patient who physically, she's amazing,
Mhm.
and she'll go out with her husband 3 times a day.
Mhm.
But her friend,
Yeah. So there's, different, so dementia patient comes to me, well, we're going to look at their hormones. That's absolutely. Is their thyroid well regulated? The Dr. Dale Bredesen's book, The End of Alzheimer's, is a great resource for you. So, look at that. So get the one with the blue cover first, because that's how to do it. And then the one with the white cover is the more the science behind it. That's a great resource for dementia. Actually, any brain, it's a good resource. Is there anything on Zoom before I sign off?